Thank you, Dr. McNeely. Good morning, everyone. So today the subject is a difficult clinical subject, the pediatric hemorrhagic cystitis, as Dr. McNeely mentioned. So the learning objectives for today will be to understand and apply the treatment algorithm for hemorrhagic cystitis in a pediatric patient, to explain the mechanisms of action of various treatments for hemorrhagic cystitis, and to discuss the level of evidence of these various treatments. We'll start with a case presentation. This is a 10-year-old boy who had a B-cell acute lymphoblastic leukemia with multiple relapses. And I will focus only on the hemorrhagic cystitis because his history and complications were pretty extensive. But this kid was admitted in April 2022 to complete the pre-bone marrow transplant workup and begin conditioning chemotherapy. He received thiosulfan, fludarabine, diazepa, post-transplant cyclophosphamide, and he had multiple complications, including pancytopenia and graft versus host disease. About 2 days after the bone marrow transplant, he had hematuria, but only traces at that point. But in the days after, he really developed gross hematuria and bladder spasm. That was in May. Oncology prescribed hydration and oxybutynin as needed. They didn't consult us at that point. Afterwards, the patient develops acute kidney injury. The creatinine went up to 172. So nephrology was consulted, an abdominal ultrasound was done, which was normal, and he tested for positive for BK virus in his urine. So urology was consulted end of May for clot retention. At first, the patient refused catheter insertion and the clots were self-resolving. And then it recurred and an abdominal ultrasound was done and showed a 5.8 centimeter blood clot in the bladder. Again, the patient refuses catheter insertion, and finally the catheter resolved on the subsequent ultrasound after observation because he was still able to pee. And then again, recurrence of urinary retention with pain and clots. So on June 6th, he had a cystoscopy, clots evacuation, intra-vesical pseudofovir installation, and insertion of suprapubic and urethral catheters. So he was on continuous bladder irrigation, but the catheters kept blocking because of the clots. So the cystoscopy, pseudofovir installation, and clots evacuation was repeated on June 13, and then on June 16 again. But this time he didn't receive pseudofovir because we were planning for alum irrigation. At that time, oncology team also started intravenous pseudofovir, 0.5 milligram per kilograms per dose. And then on June 22nd, even with continuous bladder irrigation, the catheters kept blocking. So we planned for bilateral nephrostomies. The urethral catheter was also removed and the suprapubic tube was clamped. Afterwards, he had hyperbaric chamber treatments for about 2 months, July and August. And when hematuria was less severe, end of August, I would say, we did a trial of void by clamping the nephrostomy tubes. He was able to pee. So, and the hematuria was really almost resolved. So we removed the nephrostomies and suprapubic tube in the OR and did a cystostomy closure on August 24th. Urethral catheter was inserted and removed 5 days later after a successful trial of void. Just for further information, the BK viral load became undetectable on August 9th with the IV cidofovir, and also they also lowered a little bit the immunosuppression to help. And at that point, 27 treatments of hyperbaric chamber were given. So in the end, he received 29 treatments in total of hyperbaric chamber. And they were stopped because the hematuria was resolved, and also he started to have a pneumonia. So that's another reason they stopped the treatments. So the presentation today will be mostly on the Canadian Urological Association best practice report on pediatric hemorrhagic cystitis. So this is like the core of my presentations, but also did a review of literature, and we'll talk about some more studies on that subject. So to start, how do they define hemorrhagic cystitis? Is the presence of hematuria and lower urinary tract symptoms, such as dysuria, frequency, or urgency, in the absence of other potential contributing factors, such as vaginal bleeding or bacterial, fungal, urinary tract infections. For this best practice report, the recommendations focus especially on the bone marrow or stem cell transplantation population, because hemorrhagic cystitis in children is almost always related to treatment for childhood malignancies. The reported incidence of hemorrhagic cystitis in this population is between 5 and 70%, which can be pretty high. And without successful treatment, the mortality is high as well. Cystitis are chemotherapy, of course, but especially alkylating agents. The most common are cyclophosphamide and ifosfamide. What happens also is that the situation is exacerbated by viral infections with BK virus, GC virus, CMV, adenovirus, especially subtypes 11 and 35, and simian virus 40. The BK virus is in the family of polyomavirus and is the most common virus associated with hemorrhagic cystitis. Another exacerbation of pancytopenia and chronic thrombocytopenia, which will cause bleeding and necessitate like chronic platelet transfusions. And also, let's not forget that cyclophosphamide and pelvic radiation represent risk factors for further bladder cancer. Let's talk about physiopathology. So just a little word about radiation-induced hemorrhagic cystitis, because the mechanism is a little bit different from the chemotherapy. So it's mostly through damages to the vascular endothelium that this process happens. This creates inflammation, fibrosis, and ischemia, which in turn causes necrosis and mucosal slugging. So really what to remember with radiation is that it causes progressive obliterative endarteritis. For alkylating agents, this is more about local effect on urothelium, which can be a really painful process in itself, but when there are blood clots, passage per urethra, this can be even more painful for patients. So here is an ultrasound of hemorrhagic cystitis. So just to show that this is really something that can be visible on imaging. So on the first stage, so the first ultrasound here, we see that the bladder urothelium and lamina propria are thickened and inflamed. And then there is some hematuria and eventually some adherent hematoma that we can see on the second ultrasound image. So eventually this causes like a hypervascular state, so which we see in the Doppler. And 3 months later on this image, the process has resolved. But again, just to show that this can be visible on imaging, and not just with cystoscopy, of course. So something important to understand is that hemorrhagic cystitis is caused mostly in alkylating agents, is caused mostly by the urotoxic metabolite called acrolein. This is produced by the liver and causes mucosal inflammation, edema, slugging, and fibrosis. It is dose dependent. And the big problem here is that since the bladder is a reservoir, the acrolein stays in the bladder until the patient pees. So there really is that increased contact time that doesn't help. And something that we can give to patients to prevent that is Mesna. So this binds to acrolein and renders it inert and is supposed to prevent significant bleeding. The side effects of Mesna are mostly gastrointestinal, and apparently it has a really bad taste. But unfortunately, 10 to 40% of patients will develop the condition despite prophylactic treatment. So this is a prospective controlled study done in 2015. And their objective was to compare intermittent to continuous intravenous MESNA during cyclophosphamide conditioning. And what they found was that patients in the continuous treatment group had significantly less hemorrhagic cystitis occurrences at both 30 days, 0%, and 60 days, about 6%. And on the intermittent regimen, it was 34% at 30 days and 40% at 60 days. And this was statistically significant for both. So their conclusion was that maintaining MESNA concentration in urine is key. And this really makes sense when you think that the bladder is a reservoir and the contact time of acrolein is a big factor in hemorrhagic cystitis, and that if MESNA binds with acrolein, then if the concentration is stable throughout, there's probably less chances of acrolein damage to the urothelium. So there are two types of hemorrhagic cystitis, early onset and late onset. Early onset is between 48 hours to 2 weeks, and it's mostly secondary to chemotherapy agents. And late onset is mostly because of reactivation of viruses. The management is, as usual, like we treat hematuria, right? Because at first, even if we suspect it, we don't have a confirmed diagnosis of hemorrhagic cystitis secondary to chemotherapy agents, for example. So we have to rule out other causes of hematuria, such as stones, infection, tumors, and we can do a complete blood count, coagulation profile, creatinine, a urine culture, and an ultrasound. In the pediatric patients, of course. And for cystoscopy, so I'll talk about it in the next slide, but this is part of the treatment, but we don't always need to do it as we do with gross hematuria in adults. So this is grading definitions of hemorrhagic cystitis in the COA best practice report. And what is just important to note here is that in grade 1 and 2, it's like less severe hemorrhagic cystitis with either microscopic hematuria or gross hematuria, but without clots. And grade 3 and 4, we can see small clots here that are passed with voiding. And for grade 4, it's really clots that cause obstruction and require instrumentation, for clot evacuation. And grade 5 is death. Another grading system here that I found interesting is the Karolinska grading system, and it's mostly about treatment. So again, for grade 2, we have gross hematuria, and here they say medical intervention indicated. Grade 3 is when transfusions are needed. Grade 4 is when it's life-threatening and urgent interventions are required. And grade 5 is, again, death-related to hemorrhagic cystitis. So this is the algorithm in the best practice report. Throughout the next slides, I will talk about it in more details. But always what's important to know is that we need to start with supportive treatment. So first thing to do is usually force diuresis, and generally oncology team does that already without consulting us. This can be done with intravenous fluids and even diuretics. Also, we have continuous bladder irrigation. I would say in practice, I've seen some start continuous bladder irrigation before the cyclophosphamide, and some other just wait and see how it goes. But this is something that could be done. Again, in pediatric patient, a limitation is the small urethra and catheter size. And another rationale for avoiding catheters is because the urothelium is so edematous and irritated. A catheter that is in contact with the urothelium all the time and that moves around can avoid the bleeding. Can worsen bleeding. Another supportive treatment is MESNA, as we talked about. Of course, the hemorrhagic cystitis is a painful process, so pain control and bladder spasm management is important. We can use anticholinergics such as Visicare, Ditropan, or tolterodine. We can use pyridium, intravesical lidocaine, or conventional analgesics such as morphine. I don't think Advil would be useful because of the thrombocytopenia also. And lastly, hematological optimization is important. What is mostly recommended is to keep platelets above 50 to improve hemostasis. So the COA's recommendation is that routine history and physical with imaging should be performed to confirm the etiology of hemorrhagic cystitis at onset. All patients undergoing chemotherapy conditioning prior to allogenic bone marrow transplant or stem cell transplant should receive preventative hyperhydration, continuous bladder irrigation, and mesna, as well as supportive analgesia with systemic and targeted medications at the onset of hemorrhagic cystitis with symptoms. And this is a level 3 evidence, grade C recommendation. So if that doesn't work and the hemorrhagic cystitis is of low grade, then we can start non-invasive treatments. So the first one is Elmiron or pentosam polysulfate, and this is a level 4 grade D recommendation. So this is a semi-synthetic glycosaminoglycan, and this proposed mechanism of action, I say proposed because it's not 100% clear, is adherence to the bladder wall, glycosaminoglycan layer, replacement of damaged areas, and bladder protection from irritants. Side effects are diarrhea, headache, alopecia, and liver dysfunction. The dosage is generally 100 milligrams by mouth 3 times a day, eventually reduced to 100 milligrams daily. When I look on drug information for pediatric patient, they say it hasn't really been studied in the pediatric population, but it's still included in the best practice report. A recommendation is that there is limited evidence on the positive benefits of using Elmiron in pediatric patients with hemorrhagic cystitis, and that further studies are needed prior to broad implementation. But I have found studies that were interesting. This is one published in the Pediatric Surgery Journal in 2012. This is a retrospective case note review on all patients treated for hemorrhagic cystitis from 2002 and 2010 in their center. And what they did is that they used a protocol, which was early recognition of hemorrhagic cystitis, Elmiron 100 milligrams 3 times a day, and avoidance of urethral catheterization. And they compared it to a historical cohort of 5 patients, and they only have 5 patients in their protocol, which is very few patients. But still, they found that 4 out of 5 patients in the historical cohort died of hemorrhagic cystitis, and that all recovered in the protocol group. And that blood transfusion was reduced by 88% after protocol introduction, and that was pretty statistically significant. So that their conclusion is that protocol reduces blood transfusion requirements and mortality from hemorrhagic cystitis. So again, really small cohort, but still it's interesting to see those results and to see if Elmiron will eventually be recommended more at large if there are bigger studies. Then we can use estrogens either by mouth or intravenous, and this is a level 4 grade D recommendation. The mechanism of action is stabilization of small blood vessels. It also suppresses the immune response and facilitates the repair of injured tissues. Unfortunately, with estrogens, there's quite a few side effects like liver dysfunction, hypercoagulability, which is maybe something to consider in the context of a malignancy already. And then there's hypertension, facial flushing, feminization in males, and malignant transformation. And there are really, the results in literature are really varied. So in the end, the COA's best practice report recommendation is that there is conflicting evidence regarding benefit versus harm with estrogen therapy, and that additional studies are required to clarify its use. And then we have hyperbaric oxygen therapy, which is the highest grade recommendations that we have in this best practice report. It's a grade B recommendation. So hyperbaric is used for burns, difficult healing wounds, necrotizing soft tissue infections, decompression sickness. And what it does is that it increases local tissue oxygen tension and extraction, and that has an effect on fibroblast proliferation, capillary angiogenesis, and upregulation of vascular endothelial growth factor, which leads to neovascularization, cell proliferation, and decreased edema. So the recipe is 100% oxygen at a pressure of 2 to 3 atmospheres for 90 minutes in 30 to 40 sessions. Effects can last an average 2.5 years, but the 5-year complete response rate has been noted to be only around 27%. And here, I just want to mention also that this 30 to 40 sessions, this was in the Campbell and some multiple other studies or case reports that I found. In the COA best practice report, they only mention about 10 sessions, but again, they don't specify if it was for patients that also had like positive BK virus. We don't have much information on that, but it seems that more treatments are required. So reported complications include claustrophobia in 20%, ear barotrauma in 17%, and rarely seizures. And complete resolution of hemorrhagic cystitis will be from 70 to 94%. So the recommendation is that hyperbaric chamber treatments have been proving to be safe, effective, and relatively low risk in treating pediatric patients with hemorrhagic cystitis. Its widespread use, however, may be limited due to cost and access. So this is a case report that happened on an adolescent with stem cell transplantation and chronic leukemia that also had positive BK virus and nephrostomies, similar to our patient. So he received 30 treatments for 90 minutes at 2 atmospheres from Monday to Friday. And he had complete resolution of his hemorrhagic cystitis signs and symptoms and normal or absent BK virus count in blood. So if these treatments still don't work, then we can go towards more invasive treatments with alum, prostaglandins, hyaluronic acid, and antivirals. And this is all intravesical treatments. So let's start with alum. It's a level 3 grade C recommendation. The mechanism is that it causes protein precipitation on the urothelial lining, stimulates vasoconstriction, and a decrease in capillary permeability. So the recipe is a solution of 1% alum, so about 10 grams in a 1 liter bag of sterile water, on continuous irrigation at a rate of 200 to 300 milliliters per hour. It's important to remove all the blood clots prior to start the instillation. And the side effects are bladder spasm, suprapubic discomfort, and we have to be careful with aluminum toxicity. If that happens, we can observe mental status changes, encephalopathy, and seizures. And this happens especially in patients with renal insufficiency. Something we can do to follow is measure serial aluminum levels. So the studies were sometimes controversial. There's only one single small randomized controlled trial done a long time ago in 1992 that found intravesical prostaglandin and continuous bladder irrigation with alum to be similarly effective in inducing remission of hematuria, but there was a higher incidence of relapse with alum. There was a number of case reports mentioning aluminum toxicity throughout the years and even sometimes death, again, mostly in the context of renal impairment. And on another retrospective case series in 1994 of Efros and colleagues, only one patient on 6 responded to alum. So the recommendation is that alum bladder irrigation is effective in treating pediatric hemorrhagic cystitis although the patient's bladder must be fully cleared of blood clots prior to initiation of therapy, and that patients must be monitored closely for potential aluminum toxicity, especially in the setting of renal failure. So for our patient, the alum didn't work, unfortunately. Then we can use prostaglandin. This is a level 3 grade C recommendation, and it is thought to cause vasoconstriction, platelet aggregation, and cytoprotection via mucus barrier regulation. So a recipe could be 0.75 milligrams of prostaglandin diluted in 50 to 100 milliliter of normal saline and instilled slowly in the bladder. Then the catheter is clamped for 1 or 2 hours, and we can repeat this daily until resolution of hematuria, or until the week is, or until 1 week. The adverse effect is mostly bladder spasm. It is pretty well tolerated, and then a report in 1990 of Trigg and colleagues use prostaglandins type 1, though, because this is the one that was available for them in the United States at that time. And they used it for 1 hour under sedation, and 5 out of 6 patients over 7 days had their hemorrhagic cystitis eliminated. So this is another study done in bone marrow transplant in 2003, a multi-center study, and their objective was to assess the incidence and treatment of hemorrhagic cystitis in 1,218 pediatric patients who underwent stem cell transplant. And what was interesting is that they also compared it with hyperbaric chamber treatments. So what they found is that the success rate for prostaglandin was 37%, and it was 78.5% for hyperbaric chamber, and this was significant. So even if prostaglandin therapy seemed to work partially in some patients, hyperbaric chamber treatments were in grade 2 and 3 hemorrhagic cystitis were much more efficient. So the CWA's recommendation is that prostaglandins may be of modest benefit as an intravesical therapy in pediatric patients with hemorrhagic cystitis with urethral catheters, although additional studies are needed to clarify its efficacy and if sedation or general anesthesia is required. So finally, we have irrigation of hyaluronic acid. This is a level 4 grade D recommendation. The mechanisms is that it enhances connective tissue healing, and it's possible that it may alter a step of the polyomavirus's life cycle and inhibit viral replication. And this would be through cytokines that are activated with the the recipe is an hour to repeat once a week, and the CWA's recommendation is that applications may be required, and so we can see. And then we have intravesical antivirals, so generally cidofovir. This is a level 3 grade C recommendation. So as I mentioned, we can also give it intravenous, but here I'll talk about the intravesical instillation. So it's a 5 milligram per kilogram of cidofovir diluted in 50 to 100 milliliter of saline solution intravesically for at least 1 hour. We have to be careful again for potential nephrotoxicity in these patients. So lower doses can be used, which are 0.25 to 1 milligram per kilogram per week. The COA recommends that in patients with hemorrhagic cystitis proven to be due to a virus on urine culture or PCR, targeted treatments with IV or intravesical antivirals is recommended as a low-risk treatment. So if it doesn't work, or the hemorrhagic cystitis is already high grade at the start, then we have on the algorithm table that I presented earlier, we have the different site of treatments that are mostly invasive. Fibrin from cystoscopy of hemorrhagitis. Is useful at weak evacuation and fulguration if there is some isolated bleeding. We can also, in pediatric patients, use that time to put a suprapubic catheter, because this is often a way that we can do continuous bladder irrigation. So unfortunately, three-way catheters in children is would be too small, right? Because of the small urethra and the 3 lumens of the catheter that makes each lumen smaller. Cultivation and fulguration of bleeding are a mainstay of therapy and management of pediatric hemorrhagic cystitis for their capacity to diagnose and treat hemorrhagic cystitis, as well as provide symptom relief from patients in clot retention. I have read about fibrin glue. This is a level 3 grade C recommendation. It can be done either at the time of cystoscopy or as a treatment in itself. So it's generated from the patient's own virus inactivated blood or fresh frozen plasma. Generally, they use like a big 24 French nephroscope, and the bladder is insufflated with carbon dioxide at 12 millimeters of mercury. And then the fibrin glue is either sprayed everywhere or only on the isolated on the bleeding regions. And this is kept for 30 minutes. And then a catheter is left in place, but without continuous bladder irrigation. And colleagues in 2009 showed some patients needed multiple applications. Is a prompt of video wants to be started. Anyway, sorry. So it can be a promising treatment for patients undergoing cystoscopy with clot evacuation, as it can be applied focally or diffusely. But additional research is needed to expand its applicability, as current recommendations for large caliber cystoscopes limit its use in children. Then we can use formalin, which is level 3 grade D recommendation. This is a solution of formaldehyde that induces cellular protein precipitation and capillary occlusion. We have to do that procedure under anesthesia because it causes significant pain. What's important is to rule out reflux with a VCUG before. And if there is reflux, then we can use Fogarty catheters for the ureters. The skin needs to be protected with Vaseline and the catheter put under traction to prevent any formalin dripping like elsewhere on the skin. We can start with low concentrations of 1 to 2% because it is dose dependent. And if it fails, we can repeat with 4% concentration. So generally what is recommended is to instill 300 milliliters or to bladder capacity under gravity for about 10 to 15 minutes. There are significant complications with formalin, which are bladder fibrosis and decreased capacity. And if there is formalin that goes in the ureters, then that can create urethral stricture and renal injury. but the control of bleeding has been reported in 80 to 90% of cases. So the recommendation is that although effective, the need for anesthesia with formalin and the potential long-term compromise of bladder function must be heavily considered when resorting to this therapeutic option. And finally, for refractory hemorrhagic cystitis, we can use percutaneous nephrostomy tubes. This is a level 3 grade C recommendation. And the idea is that since urine is not going to go in the bladder anymore, this removes urokinase, a proteolytic enzyme with fibrinolytic activity from the bladder so that the bladder can clot and the bleeding can stop. The COA's recommendation is that it is a temporizing measure to allow the bladder to clot off, thus managing stable or unstable hemorrhagic cystitis patients refractory to all other conservative and moderately invasive therapies. And this can be used before performing irreversible surgical urinary diversion. Something that may limit its use is persistent bladder spasm from the clotted bladder. So here we have a retrospective study that was published in the Journal of Urology in 2012. This was between 1996 and 2010. So what they did is that they placed nephrostomies in children undergoing stem cell transplant with refractory hemorrhagic cystitis. And 5 patients out of 11 had improvement within 30 days. And in these 5 patients, 4 had complete response. The average time to stabilization was 12.4 days, and the average duration of nephrostomies being in place was about 8 weeks, which is interesting because this is exactly the time that our patient needed his nephrostomies. And then we have also the supraselective bilateral vesical artery embolization. This is a level 3 grade C recommendation, which can also be useful for unstable patients. So they use a variety of embolic materials with gelatin sponge microparticles, gel foam pledgets, or alcohol microspheres. Something important to note is that the posterior branch of the internal iliac artery needs to be avoided because since the anterior branch will also be occluded, it can cause significant gluteal pain afterwards. The recommendation is that it offers modest control of hemorrhagic cystitis refractory to conservative therapy. And however, outside of unstable patients, the appropriate time point for its use requires further investigation. So here is a case series of 10 pediatrics with grade 3 and 4 hemorrhagic cystitis following stem cell transplant who failed to improve with conservative measures. It was published in Bone Marrow Transplant in 2008. So these patients had a selective embolization of bilateral internal iliac arteries, and they found a complete response in 60% of their patients and partial response in 20% of their patients. And in these 20% of patients, they saw a complete response after a second treatment. And the median time to complete response was 26 days. And then we get into the surgical measures, which are vesicostomy and cystectomy. So vesicostomy is interesting in pediatrics because we can also do some packing with lidocaine and epinephrine soaked sponges. It's easy to remove blood clots, and also it's possible to remove the catheters afterwards. So this is a level 4 grade C recommendation. In their case, Gander and colleagues also used a gel port to secure the bladder mucosa against the abdominal wall because the bladder was so edematous and fragile. And it prevents adequate suture fixation. The COA's recommendation is that despite a lack of high quality studies, cutaneous vesicostomy in the terminal or refractory pediatric patients offers potentially reversible direct bladder access for clot evacuation and application of topical therapies, while also allowing for, as I mentioned, possible removal of painful catheters. And then the last treatment is cystectomy, which is level 4 grade C. And this is really if all options are exhausted because it's irreversible. Surgical approach and urinary diversion selection varies according to surgeon. It has been described to do just like a supravesical urinary diversion without cystectomy, like just an ileal conduit, for example. But there was a higher rate of complication and notably the risk of pyocystis. And then we can do like a complete cystectomy or a supratragonal cystectomy with bladder neck preservation if the ureters are unobstructed. So the recommendation is that cystectomy is reserved as a treatment option when all other efforts to control hemorrhagic cystitis have failed. And long-term implication of this option must be considered, especially in the pediatric population, as well as the fitness and stability of the patient for whom it is chosen. There are also experimental treatments, which are level 4 grade D recommendation, and the treatments that are being studied is mostly through either rebuilding injured bladder mucosa or augmenting the coagulation cascade. So I won't get into details for lack of time, but examples are recombinant human keratinocyte growth factor, epidermal growth factor, placenta-derived stromal cells, adoptive transfer of viral-specific T cells, factor 7, factor 13, and mesenchymal stem cells. And the recommendation is that their therapeutic use to treat hemorrhagic cystitis is not recommended until further robust trials demonstrate their safety and benefit. So going back to the treatment algorithm, so we talked about preventive and supportive treatments, and then for low-grade hemorrhagic cystitis, we talked about non-invasive medication and hyperbaric oxygen therapy, and then invasive intra-vesical irrigation if this fails. And if the hemorrhagic cystitis progresses or is already high-grade with blood clots, then cystoscopy and clot evacuation will be indicated. And possibly fulguration or fibrin glue. And then there's also formalin that is before the nephrostomies and embolization in this algorithm. Personally, I've seen formalin mostly like as a last resort treatment before cystectomy because of how it can impact future bladder function, especially in pediatric patients. And then for refractory hemorrhagic cystitis, we talked about nephrostomies, angioembolization, vesicostomy, and cystectomy. So these are my references. And thank you, everyone, for your attention. I hope this was instructive and showed how this is clinically. And really, we have to, try one option at a time, going from more conservative measures to more invasive measures, and adapting our treatment to individually to each patient. So thank you. And do you have any questions?